I'm Salma Schimmel, talking to you from the 35th ESMO Congress happening right now in Milan, Italy. And our discussion continues now in the area of non-small cell lung cancer. We're joined by Dr. Suresh Ramalingam. And you come to us as Associate Professor, Chief of Thoracic Oncology, the Director of the Medical Oncology at Emory University School of Medicine.
Yes, correct.
Welcome, and I'm excited because we just were recently at the ASCO meeting and there was so much talk about lung cancer and in particular non-small cell lung cancer, and apparently the discussion continues here at the ESMO meeting.
Absolutely. Thank you, Salma. It's a pleasure to be here and to meet your audience through this forum.
So talk to us about the study that you've presented here as a follow-up to what was done at ASCO.
Sure. So everybody is now aware of EGFR inhibitors like Tarceva and Iressa, also known as gefitinib and erlotinib, in non-small cell lung cancer. We refer to them as the first generation compounds since they were the first to come off the blocks. Now, with better understanding of the biology, we have newer set of compounds called the second generation EGFR inhibitors. And our trial that we presented at this meeting involves PF299804. That's the second generation irreversible EGFR inhibitors. So the difference is these compounds block the receptor, but the effect is more sustained and non-reversible. So we did this randomized trial to compare how the new second generation drug fares to the older first generation Tarceva. So this was a randomized trial for patients with advanced stage non-small cell lung cancer, where there was one-to-one randomization between Tarceva and PF299804.
How many patients were enrolled in this?
So approximately 180 patients were enrolled, 90 patients per arm on this trial. And the primary endpoint of the trial was progression-free survival. And I'm happy to say that the trial showed that for patients who received the PF299804, there was a significant improvement in progression-free survival over erlotinib.
For what period of time?
So the median progression-free survival was 8.4 weeks for erlotinib, and it was 12.4 weeks for patients treated with PF299. More importantly, even more exciting was for patients who have the wild-type KRAS, which is present in approximately 60 to 80% of all non-small cell lung cancers, we saw near twofold improvement in progression-free survival from 8.5 weeks to 16 weeks with the new drug. So we were very excited about these results.
What happens now?
So the next step is we are discussing the possibility of launching a phase 3 trial. As you know, this was a phase 2 trial randomized. It was actually done across the world with centers from Europe, North America, Asia, and as far down as Australia. So we think that this trial represents the entire global patient population of non-small cell lung cancer. The next step is to do a confirmatory phase 3 trial, and that's being planned.
You know, it seems to me that there's so many more challenges being presented on behalf of the lung cancer patient in understanding all the molecular characteristics of one's tumor before you can even begin to decide how to treat that patient.
Absolutely, and I think that's the new direction. We are all learning to look at patients as individuals as opposed to everybody with lung cancer to get the same treatment. Now we are able to characterize the tumors molecularly, and we at least have some examples where we can actually identify and treat based on a molecular characteristic.
We talk a lot about the molecular and new targeted therapies. We don't talk as much about, especially to patients, their understanding of the diagnostic tools, the technology involved in helping to understand the molecular characteristics of their cancer.
Sure. I think as we learn more about these, even among the patient community, the awareness is increasing. It's not infrequently that a patient would come to me saying, I've had the EGFR testing done, this is what it showed, and what treatment should I get? My doctor recommended option A, and should I continue that, or should I try something else? So I think there is a process where we have to educate ourselves and educate our patients as to what these nuances are and how these influence various treatment options. But this is an exciting time.
Yeah, there's no doubt that for lung cancer, you know, there was a long period of time where you couldn't sit down and report positive findings and they're pretty intense over these last few years, and it's it's pretty amazing when you look at the history and the evolution of the treatment of this disease.
Absolutely. I think one would not have predicted 10 years ago that lung cancer would be the poster child for individualized therapy among all other cancers.
What do you see the future role of standard chemotherapy in association with the targeted therapies? Is it going to continue to be a combination therapy protocol?
I think what we're seeing is there are newer chemotherapy regimens being added. Now we have chemotherapy drugs that are better tolerated compared to some of the older drugs we have. So I don't see a role for chemo going away for all patients, but certainly for subgroups of patients, we're going to be using these targeted treatments ahead of time. Combinations in some cases may work, in some cases it has not worked. What we think is an attractive targeted drug when you add it with chemotherapy does not necessarily add up to be a good regimen. So this will also be variable based on the kind of drug and target you're talking about.
You know, before we sat down to have our discussion, I was sitting with the president of the multinational supportive care organization for cancer, and it made me think about some of the issues and the challenges that medical oncologists face, especially with therapies that are orally based, which is pretty common in lung cancer, and how you cope with concerns about patient compliance and how you are dealing with some of the side effects that in this case deal with the skin and the rashes. Will you take a moment to talk to us about that?
Sure. I think with oral therapies, we are now seeing toxicities that are different from the traditional chemotherapy-induced side effects. So with EGFR inhibitors, skin rash, diarrhea, dry skin, these are some of the more commonly experienced toxicities. If you look at, for instance, in the trial that we have just reported, the PF299804, we followed patients for various symptoms and quality of life parameters. And in fact, we were able to show that for patients who got the new drug, PF299804, there were more favorable outcomes in terms of fatigue, pain, cough, and various quality of life and symptom parameters. So I think increasingly we are going to be looking not only at efficacy, but also how these drugs affect patient quality of life, patient functionality, and symptoms. So these are important endpoints, and this is why in our trials now we are including these endpoints.
And when do you expect that you may be able to report on the next phase of your research?
Well, as we are planning the phase 3 trial, as you know, these trials are going to take several hundred patients to enroll. So it's our hope that the exciting results of this trial will accelerate that process, and hopefully in the next couple of years we'll be able to report on the phase 3 trial.
Which means you'll be sitting in this chair and you're going to be giving more positive data, is that right?
I think we all can use positive data and new drugs for our patients because lung cancer is unfortunately not going away in the near future.
So a closing thought, as an American attending this European meeting, what has impressed you most and what are you going home with?
I think this has been a very interesting meeting. We are seeing some new data presented for the first time, particularly with the irreversible EGFR inhibitors. I think these drugs are here to stay, and the results we've seen so far clearly have confirmed biological activity. How they will fit in the individual treatments, we'll have to let these trials answer. But it's been a very good meeting for lung cancer and patients.
Well, you have a smile on your face, so I hope that not only are you inspired clinically, but that you are enjoying Milan.
Absolutely, who cannot?
Indeed. Thank you very much, Dr. Suresh Ramalingam, who comes to us from Emory University in the United States.
Thank you very much. It's been a pleasure.